The human heart beats roughly 100,000 times a day. To do that, the muscle fibers have to precisely relax to fill with blood, and then contract with enough mechanical force to push that blood through miles of vessels. Usually, when we look at cardiovascular disease, we are looking at clogged plumbing, like coronary artery disease, or faulty electrical wiring that causes an arrhythmia. But there is a completely different category of danger, when the muscle tissue of the heart itself breaks down. These are the cardiomyopathies. Cardiomyopathy translates directly to heart muscle disease. In these patients, the foundational physical architecture of the myocardium degrades, destroying the organ's basic ability to pump or fill. This diagram shows the core classification module for the disease. We can group these structural anomalies into 4 distinct physical profiles based on exactly how they fail: hearts that become big, thick, stiff, or chaotic. Identifying which specific physical defect is occurring is the essential first step. A physician has to map out exactly how the structure has deformed to safely manage the symptoms before they can track down the underlying cause. Looking at the blue column on the far left of this chart, we start with dilated cardiomyopathy, or DCM. This is the big floppy pump. The core problem here is systolic failure. The ventricles stretch out and become profoundly weak, severely lowering the ejection fraction, the percentage of blood the heart pushes out with each squeeze. This stretching usually starts with a direct insult to the heart muscle cells, known as myocytes. As the box shows, that initial injury is most commonly driven by ischemic heart disease, but it can also be triggered by chronic alcohol toxicity, a viral infection like Coxsackie, or genetic mutations. By the time a patient presents with DCM, they look like a classic congestive heart failure case. Because the weak pump leaves fluid behind, patients experience shortness of breath, peripheral edema, and a heavy, abnormal third heart sound known as an S3 dollop. On the opposite extreme is hypertrophic cardiomyopathy, or HCM. Instead of a weak, stretched wall, the sarcomeres, the basic contractile units of the muscle, generate far too much force. The cells overwork, and the central septum thickens so much that it bulges inward, physically blocking blood from leaving the left ventricle. This massive wall of muscle creates a stiff chamber that struggles to relax, causing diastolic failure. Under a microscope, the cells grow in completely random, unaligned directions in a state of myocyte disarray. And because this thick muscle demands more oxygen than the local capillaries can supply, the tissue suffocates from localized ischemia. HCM is heavily driven by dominant genetic mutations, and it frequently appears in young athletes. The warning signs are usually chest pain or syncope, meaning fainting, during physical exertion. The disorganized electrical conduction through that chaotic, thickened muscle puts these patients at immense risk for sudden cardiac death. Managing HCM comes with a dangerous treatment paradox. If a doctor uses standard heart failure medications like nitrates or diuretics to reduce preload, the initial stretching of the heart before it contracts, the ventricular chamber shrinks. In an HCM patient, a smaller chamber brings that sick septum even closer to the outer wall, completely clamping down the outflow tract and making the obstruction far worse. Moving to the green column, we find restrictive cardiomyopathy, or RCM. Here, the heart is a rigid, stiff chamber.
The ejection fraction is usually normal, meaning the heart can still squeeze, but the muscle is so inflexible that it suffers from diastolic dysfunction. It simply cannot relax enough to pull blood in. RCM develops when the healthy muscle is infiltrated and replaced by stiff external materials. The classic culprit is amyloidosis, where abnormal proteins deposit into the tissue, but it can also be driven by iron buildup in hemochromatosis, or scar tissue from previous radiation therapy. Because the rigid ventricles refuse to expand, blood trying to enter the heart hits a wall. This creates a severe backflow into the veins, mimicking congestive heart failure. Patients develop marked jugular venous distension in the neck, a swollen liver known as hepatomegaly, and severe fluid pooling in their legs. The fourth category is arrhythmogenic right ventricular cardiomyopathy, or ARVC. This is an inherently chaotic muscle, where the structural integrity of the heart wall literally disintegrates over time under the normal mechanical stress of beating. It stems from genetic mutations in the desmosomes. the tiny protein bridges that anchor individual muscle cells together. The cellular adhesion is so weak that the myocytes detach from one another, undergo programmed cell death, and are eventually replaced by dead patches of fat and fibrous tissue. This fibro-fatty replacement physically cuts through the internal electrical pathways that tell the heart when to beat. The resulting electrical disruption triggers severe palpitations, fainting spells, and puts these patients at a very high risk of sudden death at a young age. A massively dilated heart looks nothing like a rigid amyloid-filled chamber on an ultrasound. But beneath these distinctly different physical defects and clinical profiles, the muscle tissue is actually hiding a shared, devastating mechanism. Looking at the gray oval at the bottom of the diagram, we see the ultimate takeaway. Regardless of whether the initial insult makes the heart big, thick, stiff, or chaotic, the organ's desperate attempts to keep pumping eventually trigger an identical cellular self-destruct sequence. It starts with mitochondrial failure, plummeting the available ATP energy supply. Without enough energy, the circa pumps, which normally clear calcium out of the cell after a contraction, begin to fail. Toxic levels of intracellular calcium build up, directly poisoning the muscle tissue. In response to the dropping cardiac output, the body activates the sympathetic nervous system and the RAAS pathway. RAAS is the renin-angiotensin-aldosterone system, a hormone cascade that manages blood pressure. This neurohormonal overdrive bombards the failing heart with adrenaline and angiotensin, forcing extreme vasoconstriction that makes it even harder to pump. The final blow is a surge of cytokines, proteins that signal the immune system. They trigger severe inflammation and cell death, steadily replacing whatever working muscle is left with useless fibrotic scar tissue. For physicians, this creates a dual battlefront. They have to correctly identify and triage the specific physical defect to keep the patient alive today, but the long-term war is fought entirely against this shared molecular remodeling. This quick differentiation table summarizes the entire diagnostic framework. To treat a cardiomyopathy, you isolate the ejection fraction and pinpoint the core mechanical problem, whether a weak pump like DCM, a filling obstruction like HCM, or an electrical hazard like ARVC. By locking down the physical structure, a doctor can anticipate the primary risk and intercept the failure before the muscle destroys itself completely.